Good afternoon, everybody, and welcome to yet another webinar from the Royal College of Surgeons of Edinburgh. This series is organized by the Regional Surgical Advisors of the College, and we're really thankful to the College and the network for organizing this. My name is Mike Silva. I'm a consultant liver and pancreas surgeon based in Oxford. And today we've got my friend, colleague, and co-worker, Mr. Dennis Remondas, who is an oncoplastic breast surgeon who works with us in Oxford, talking to us about gynaecomastia. Dennis I've known for many years and is an excellent speaker and has an interest in collaborative audits, especially in those incorporating trainees, looking at breast implants and reconstruction, as well as other studies that involve the margin positivity when operating on breast cancer. A few housekeeping points. There is a question and answer facility that you have. Please use it and save your questions for the end of the talk once Dennis has finished, so that you know what he's going to say before you ask the questions. In addition to that, remember Thursday we've got esophageal reflux and hiatus hernia being covered by Cynthia Borg, who's presented to you before. Over to you, Dennis.
Thanks, Mike. Good afternoon, everyone. It's my first webinar, and I do find it a bit sort of weird not being able to see all of you. I hope you can hear me clearly. As Mike said, I'm Dennis Remondas. I'm a breast surgeon in Oxford. I've been in my post for nearly 5 years, 4.5 years. And I've been involved in quite a few trainee projects. As a student, I was never sort of taught any benign breast disease, and actually benign breast disease is much commoner than cancer, yet we don't see it much in hospital. So it was a privilege to be able to talk to you about gynaecomastia, and I think the main thing is to say what the basic things you need to know for your level, and probably for your level as even sort of SHO stroke junior registrar. So what we'll try and do is talk about what is gynaecomastia, discuss the causes, and then see how you can assess gynaecomastia in clinic, whether you're a GP or whether you are in secondary care, and then talk about investigations and treatments that are appropriate. So there are two different entities that can be confused as gynaecomastia. True gynaecomastia, the hyperplasia of male breast tissue is basically the breast, and this happens as a response to or as a change in the estrogen to androgen balance. So your estrogens go up versus the testosterone goes down, or something along those lines. There's another entity called pseudogynecomastia. That basically is what probably people say in the streets as man boobs, and there's no other way to describe it, but basically is fatty tissue around the breast. This is not gynecomastia, it's adipose tissue. And none of the stuff that we're going to talk about today applies to pseudogynecomastia. And what is gynecomastia? Being Greek, I have to use this, but basically it's woman's breast. Many patients don't want to know that, but that's what it means. So if you look at the difference here, I don't know if you are old enough or young enough to have seen Austin Powers. On the right-hand side, you've got fat bastard who basically has got a lot of adipose tissue around his breast. Whereas on the left-hand side, you can see just the male breast tissue, just the tissue behind the nipple is enlarged, and that would be in a type 1 gynecomastia, but that's less of a relevance to you. Just as an overview, there is the Simon classification of gynecomastia, and what you need to know about this is you can have a breast tissue enlargement, you can have skin enlargement, or you can have sort of both, depending how much it is. Causes of gynecomastia, otherwise known as the 3 Ps. These are the main causes, otherwise you can go through your surgical sieve, but the main causes are physiological, pharmacological, and pathological. Physiological, you get it in newborns. And in newborns, there's been a transfer of estrogens from the mother in the placenta. The estrogens stay in the body for significantly longer, and therefore they stimulate the breast buds. With time, over a few weeks, the breast buds will settle. And particularly for first-time parents, it can be quite distressing. Things that there's something wrong with their baby, but actually there's absolutely nothing wrong with the baby. And about 90% or up to 90% of newborns can actually get gynaecomastia. Then you've got gynaecomastia during puberty. And the reason for that is that the estrogen production starts before the progesterone production, the testosterone production, sorry. And up to about 70% of men will get some sort of degree of gynecomastia. So we're talking about very common entities. The good news is that actually in most teenagers, it settles within about 6 months. And again, the vast majority, probably in excess of 90%, it will have settled by 2 years. Now, in some people where it persists beyond the 2 years, it can actually become more fibrotic, and then it probably will never resolve after that. Then the third type of physiological gynecomastia is the senile, or I prefer it as sort of the senior gynecomastia. And we know that about 60 to 70% of men over the age of 70 will develop gynecomastia. And that's because their own testosterone is reducing and the estrogens stay about the same. Many people put on weight. Weight is associated with increased estrogens, and therefore you get a high estrogen as well. The second commonest cause is pharmacological. And pharmacological, I don't mean just a drug that we're giving, so medication. It can be any sort of medical cause. And how do they do it? Every drug is slightly different, but basically either they stimulate estrogens directly, they block the androgen receptor, a combination of both, or they stimulate more, they inhibit more the androgen production. And I don't know if you remember, but the aromatases, and we use aromatase for aromatase inhibitors in breast cancer quite a lot, but the aromatase is an enzyme that converts testosterone to estradiol, to estrogen basically. So if you inhibit the production of androgens, then you end up with more estrogens. So I've got a question for you now, if that's all right, if you get your hands on the buzzer. Which of those drugs do you think are causing gynecomastia? I can see that about half of you put all of the above, and actually that is the correct answer. It took me a while to realize that methadone and prednisolone, as well as omeprazole, that no one actually chose, all cause gynecomastia. They are probably some of the, not probably, they are some of the commonest type of medication. And I've got, oops, sorry, there you are. There you are. And you can see a long list of drugs here. And I'm not going to go through all of them. There is no need. You can have access to the presentation. But lots of common drugs that we use in our everyday practice, they cause gynecomastia. Similarly, recreational drugs, cannabis, alcohol, heroin, methadone, amphetamines, all of these are actually one of the commonest cause for seeing young people in clinic with gynecomastia. And the other thing that really takes people by surprise is protein shakes after people having been to the gym and soy-based products. They also cause gynecomastia. So a young fit man that tells you they haven't done any steroids may still be getting gynecomastia because of the protein shakes. So it's worth educating them if you see people with gynecomastia. And I'm sorry to all the men or boys I'm disappointing at the moment. The third commonest cause is pathological. So what is going on? What is the pathway? So the normal pathway is that the hypothalamus will release GnRH. GnRH then stimulates the anterior pituitary, which then releases FSH and LH, and then goes to the testes. And as a result, you get testosterone or inhibin, either of the two, then give you back a feedback mechanism to block the release of GnRH, FSH, and LH. Very simplified way, okay? And you can see it. I've put at the bottom, it is a lot more complicated. I don't need you to remember all of this. This is endocrinology. You can go and look it all up. But you can see that in these pathways, you can have adrenal or testicular tumors that don't really respond to the feedback mechanism. And therefore, you can have an increased activity of, or increased release of estrogens, testosterone, stimulation of the aromatase, or you can have HCG released by the tumor. You also can get primary hypogonadism, so it can be testicular failure, where that's mumps or an undescended testis, or they can have a genetic abnormality like Klinefelter's. You can have secondary hypogonadism, and therefore, again, you don't make enough testosterone due to hypothalamic or pituitary causes. Sometimes people get pituitary tumors, like a prolactinoma, and that can, again, suppress the testosterone production. But also, you get other conditions like thyrotoxicosis, acromegaly, and androgen insensitivity. And I don't want to go into the details of all of these because some of these mechanisms are not fully known. Some of them have got multiple ways of working, but you just need to be aware that all of these systemic things can have, endocrine systemic problems can have an effect on gynecomastia, can cause gynecomastia. And then talking about systemic, there are other illnesses like liver cirrhosis, renal failure, malnutrition, obesity, and HIV that again can give you gynecomastia. So why are we interested in gynecomastia? Well, it's very common. It's by far the commonest presenting complaint in men coming over to the clinic. And while I have to say, probably the specialist breast surgeons are not particularly concerned about a man coming with a breast lump because usually it isn't anything, patients are concerned about the lump. They are worried because they know someone who had breast cancer, female who had breast cancer, but they are worried that it might be, there might be the rare situation where a man gets breast cancer. They're also worried about cosmesis. It doesn't look good. These young men with bilateral gynecomastia are wearing a tight t-shirt. They're completely ripped, but actually they've got a bit of a lump behind their breast and their breasts stick out when they're wearing tight tops. They don't like it at all. And as far as the GPs are concerned, they don't want to miss the rare malignancy or an underlying breast pathology or a systemic pathology. So that's why there's so much interest in gynecomastia. So I've got another question for you. How many new cases of male breast cancer do you think are in the UK every year? And that would be invasive and non-invasive. And again, half of you have gone correctly for A. It's only about 400 actually, whereas there are about 57,000 cancers in women every year. So it's a rare entity, okay? And I think that's very, very important. So there were 56, I think, thousand invasive female cancers and another 7,000 or so non-invasive cancers in women in 2017 in the UK, versus about 390 invasive and about 40 non-invasive in men. And only about 1 in 100 breast cancers are in men. The other 99 are in women. So male breast cancer is rare. But as I said earlier, up to 70% of men over 70 will develop gynecomastia. So when you see someone with a lump sort of in the breast or a swelling in the breast, the probability is that this is gynecomastia and nothing more. serious and important? No, probably not most of the time. But some of these causes for gynecomastia may need treatment. And I have picked up the odd person that had a prolactinoma. It is rare. So if we talk about a case I saw a couple of years ago, it's a 23-year-old man presented with a lump in his breast for 2 months. It was tender, rubbing on his T-shirt while at work, which is a very common sort of way of presenting. Very strong family history of cancer. His mother and his grandmother died in their 30s from breast cancer. He's fit and well. No other medication or no medication or allergies. Drinks about 24 units of alcohol. Denied any cannabis. And previously had taken protein supplements, but not for a couple of years. Back to you. What do you think is the most likely diagnosis? Adolescent, adult gynecomastia, breast cyst, pseudogynecomastia, or breast cancer? Just take everything into consideration, what we said in the last few minutes. Half of you are listening. Very good, at least half are listening. The commonest thing, the most, I know, I can see what you, oops, sorry, let's go back. I can see that some people might actually have been trying to say you need to exclude the breast cancer, you need to make sure it's nothing else. But actually he's 23, so he's post the adolescent years, and it's a very short history of a lump. So actually he's an adult, it is adult gynecomastia as a most likely diagnosis. Certainly with his family history, you need to exclude the cancer. Certainly you need to make sure that you control his alcohol, or get him to reduce his alcohol intake, and check that he doesn't restart taking protein supplements. So how do we approach a patient with gynecomastia? Well, you don't know it's gynecomastia until you have fully assessed them. So just like every other thing that you've done in your medical school, you need to get a history. In the history, you need to look at the patient, so you need to get the history of the presenting complaint, and then you need to go through past medical history, family history, social history, drug history, and allergies. And as an example, you need to firstly ask about the lump, and I know you get told 20,000 different things to ask about the lump, but specifically for gynecomastia, you need to know about the size, the site, the laterality, don't forget right and left, don't forget if it's both sides, and whether it's changed. Is it tender? Breast tenderness or breast lump tenderness is a good sign as far as we are concerned. Have there been any skin changes or any nipple changes? Has there been any nipple discharge? And certainly, if you look for blood-stained nipple discharge in a man, it would be a cancer until proven otherwise. And it can be proven otherwise, but until proven otherwise, you need to consider they've got a malignancy. Have they had adolescent gynecomastia? Many people that had adolescent gynecomastia then go on to develop adult gynecomastia again. And is there any past history of genetic disorders like Klinefelter's, as I mentioned earlier, or breast cancers? A lot of history of breast cancer in the family. Smoking, alcohol, and cannabis, and specifically ask about cannabis. And again, ask about medication, steroids, testosterone that people use when they go to the gym, and recreational drugs. And don't forget the protein supplements, because that is something that they haven't even registered in the intake. And with the examination, just again, like any other patient, to stick to your principle. If you panic during an exam, well, you inspect, you palpate, you percuss and auscultate. In gynecomastia, the last two will not be necessary. So what do? You inspect overall, look at the overall well-being. Is there any signs of systemic disease? Are they cachectic? Are they obese? Do they look more feminine than you would expect? Do they have the bodybuilder look? Is there basically a hint that they might be taking steroids but not admitting to it because they might have done so illegally? And then look at the breasts and look at both sides to be able to compare, because they may have noticed a lump on the right because it's a bit bigger, but there might be a lump on the left that they haven't noticed. And examine the lymph node basins. So you examine the axilla, the infra and the supraclavicular lymph node areas. And look in the breast, are there any skin nipple changes, nipple inversion, nipple discharge? And then specifically about the lump, see if it's tender, see if it's dense, if it's mobile, if it's fixed. There wouldn't be any pulsatility, fluctuations in temperature. But I can tell you, dense gynaecomastia can feel just like a cancer on occasions, but it's a bit more sort of like defined. And when I started as a doctor, I used to think frequently that a gynaecomastia may be more suspicious than actually what it was. Then you need to move on to the abdomen, specifically look for liver disease, hepatomegaly, look for your caput medusae, your spider nevi, and look at the external genitalia. Apart from looking at the size of the penis, size of the testes, you're feeling particularly for testicular lesions, and even a small, like sub-centimeter testicular lump can cause hormonal abnormalities. So how would you investigate now this 23-year-old man that we just said has probably had adult gynecomastia? What would be your next choice of investigation? The next line would probably be, just because he's a higher risk patient, would be an ultrasound scan. Because it's a sort of more interesting history, I think it would probably be inappropriate to just discharge him, even though he's 23, so he's under 25 when you would normally be discharging him. Because there is family history, he needs to be investigated further. So generally, there's no need to investigate adolescents with the pubertal gynecomastia, elderly with senile gynecomastia, and if you can find a sort of a cause for it, prescribed or recreational. But eccentric hard masses, rapid enlargement, persistent gynecomastia, or if there's anything in the history that doesn't really fit, either they are very lean or there's family history, you need to investigate further. And if that's the case, the ones that you suspect a malignancy, you need to send to the breast unit. Because of all the causes of gynecomastia, these are the lots of blood tests that you need to request. And most of these need to be done or could be done in the primary care. They don't need to come to the hospital to have them done. Because if you pick up something, you send to the correct service and not to the breast unit. And imaging-wise, when they come to the secondary care, if it's bilateral, you may not need investigations. But if there's any suspicion, probably the first line would be an ultrasound scan. If that is highly suspicious, then they get a mammogram, and then they may need to get a core biopsy. And a testicular ultrasound scan if you found something or the blood tests are abnormal. And if there is nipple discharge, you can send that off for cytology. And you can treat them with tamoxifen or anastrozole, which is an endocrine treatment, but that is off license. Or you can just tell them to stop the precipitating factors. I would never treat them without them having stopped the precipitating factors. Or in some people where it persists, you can treat them surgically with either an excision of the breast tissue, excision of the tissue and the skin around it, depending on the size of the gynecomastia, or do liposuction. But a surgical excision generally has significant litigation. Patients are not happy if they're not consented appropriately, because there might be sort of minor asymmetries, sensory changes, or a bit of cupping, a bit of divot of the nipple. I think we've covered quickly, but sort of the main causes of gynecomastia and how you need to investigate them. Most people need to do need to have blood tests if necessary in the primary care. If there is any doubt, any worries, then they need to be referred to the secondary care. Any questions?
Excellent. That was so clear and concise that even I understood, which is
Says a lot.
and very helpful. The other striking fact that I glean from this is that if I, as a GP, for example, see a patient of that description, that there are a few things that you can do and then decide the referral pathway accordingly, rather than send the patient straight to a breast service. And that is really interesting and key to know. So the blood test that you recommend, along with the full blood count and the hormonal screen, will really be helpful whether you send the patient to an endocrinologist.
Yeah, or a urologist, yes. So it's interesting, the Breast Association has got these guidelines that say originally these things need to be tested by GPs, and in all the GP education days, we're trying to say that to them, and many of them have done it. But I have to say it's difficult sometimes when someone presents with a lump, the GP is in a sort of difficult situation to say, oh, you know what, I can't send you to the clinic. And then we have to deal with it. But I think it can offer a lot more quick reassurance to everyone if we know that the blood tests are fine, and then we can look at the next level, which is what kind of imaging do they need, if they need any. And I can see some of the questions here. If what's the commonest type of breast cancer in men? It is actually ductal breast cancer, and there's just a slightly higher incidence of papillary cancer, if I'm correct. But again, that's still very rare. The vast majority of men get the same type of cancer as women. Gynaecomastia is not premalignant. It is what it is. It's just a swelling of the breast tissue. It is not premalignant. Having gynaecomastia doesn't predispose you to breast cancer. And to my understanding, having a BRCA mutation wouldn't make any difference to whether you get gynaecomastia or not. But if you have a BRCA mutation, you would be at a significantly higher risk of getting male breast cancer. Talking about this, just going a bit off on a tangent, but if you have a BRCA mutation, the average woman has got probably about 12-13% chance of developing breast cancer in her lifetime, about 1 in 7, 1 in 8. If she's a BRCA carrier, depending which studies you read and which mutation it is, between 60 and 90% chance of getting breast cancer. In men, if you're a BRCA1 or BRCA2, your maximum chance, which is with BRCA2, of getting breast cancer is probably about 4%. So it's still about a third of the average woman. So male breast cancer, even in BRCA carriers, is still very rare, and that's why they don't get offered. They don't get offered screening. Sorry, I've just seen the next question about buttonhole mastectomy. I don't know. There are different ways of describing a lot of different things, and everyone uses their own method. So I'm not entirely sure what is a buttonhole mastectomy. I'm sorry for that.
Dennis, the other interesting thing that I've come across as a practicing doctor before I became a surgical trainee is that you get young males who present with unilateral gynecomastia, and that is even more cosmetically troublesome for them. So apart from the cosmetic problem, how do you explain the unilaterality, if at all there's an explanation, and should you as a doctor worry about that?
Many people are different between right and left, whether it's men and women, whether it's testes and breasts, whatever it is. It is less common to have a significant difference between the breasts in men. So you have a significant difference between gynecomastia on both sides. Most men will have gynecomastia on both sides in those cases, but it will just be that one side is significantly less than the other. My worry with this actually is the psychological impact it has, and not actually any worry about whether there's more disease or It's just that one side has decided to respond to that estrogen testosterone level more than the other side. But psychologically, these men are a lot more affected. And unfortunately, at the moment, there is no such, there's no availability of treatment on the NHS. There's no funding for this. There used to be some in some areas. I think up north, there is a bit more lenience about this. But certainly down south, people have to self-fund for this. And it can be expensive and it can be cumbersome. And many people just wear baggy T-shirts and they suffer silently. And I think that is that's difficult. But you need reassurance that there's nothing wrong with them. It's something physiological. It may or may not settle, but they shouldn't worry about it.
That's excellent, Dennis, and I guess that also explains and answers the last question. So if you've got a male patient who has quite significant gynaecomastia that is probably physiological, you probably don't need to trouble the patient by telling them they should self-examine because the risk of cancer is so minute. So, I mean, the main thing is to recognize that it's a benign entity.
It's a benign condition, exactly.
But it's a common problem. It's not recognized as such a common problem because of the non-significance of cancer, isn't it?
Yes, and I think it's a lot of the studies have been done in there have been population studies, and they've identified that up to sort of 70-80% of teenagers get gynecomastia. And to be honest, you wouldn't expect a teenager to go to the doctor. They just kind of sit at home and they suffer through it. And that's why I think we are not even aware of how common it is, because the teenagers are a bit less confident. They just keep their head down. They don't seek advice. And it's only these population studies that have actually shown that it's a lot commoner than we think. But the reassuring thing is actually more than 90% of those cases will actually settle on their own.
Excellent. Thanks a lot, Dennis. I know you are able to do a few more talks in a few more weeks, and I'm really grateful. And on behalf of the college and the RSA network, thank you very much for that very clear, succinct, and to me, enjoyable talk.
Cool. Thank you, Michael.
And just to remind our participants that Thursday's talk will be on gastroesophageal reflux at the same time. And